Today I welcome you all to the sixth edition of KSOS PG classroom. Today we are having Dr. Anjita from Little Flower Hospital Angamali as the student, and Dr. Padmaja Kumari Rani from LV Prasad Eye Institute. She is the network head as well as the vitreoretinal surgeon with more than 160 publications as the examiner, and Dr. Divya Balakrishnan, the senior consultant vitreoretina from LF Hospital Angamali as the mentor. So in this, the student will present the case and the examiner will discuss, and this will be very useful for all the postgraduates. So let us start the case discussion with Dr. Anjita. Over to Dr. Anjita, please.
Good evening, everyone. So, myself, Dr. Anjita from Little Flower Hospital, Ankamali. And first of all, I would like to thank KSOS for giving us this opportunity, and also my mentor, Dr. Divya, for guiding me through this. And so, coming to a case presentation. So, this is a 67-year-old female resident of Alapura. She presented to OPD with complaint of defective vision in right eye for 2 weeks and black spots moving in front of right eye for 2 weeks. And the defective vision was sudden in onset, but was gradually progressive and painless in nature, with a history of floaters for 2 weeks. And there was a history of sudden onset defective vision 8 years back. And there is history of 4 doses of intravitreal injection Avastin taken in right eye.
Voice lost, I think.
Anjita,
Phobia, headache.
Anjita, are you there?
Yes, ma'am.
Yeah, your voice is, you're not audible.
What is the brand name, Anjita, of Avastin? Generic name, sorry.
Bevacizumab.
Yeah, so try to write in generic names only.
Okay, madam.
Anjita, you have to be more louder, I think.
Yeah.
Your voice is very feeble.
Louder, and is the net connection is little weaker or what? Because we should see at least one surface.
No, actually, I'm unable to start video.
Continue.
Continue, yeah.
There is no complaint of redness, pain, or discharge. No complaint of watering, photophobia, headache. There is no complaint of glare, colored halos, and diplopia. No complaints of distorted vision or flashes. There is no history of trauma or ocular surgeries in the past. No history of any frequent change of glasses.
Okay. So I want to ask you one question, Anjita. Why you are asking, why you are telling no evidence of redness, pain, and discharge? Because you said patient having history of floaters in the right eye for 2 weeks. So why you wanted to rule out redness, pain, and discharge?
Actually, patient was complaining of defective vision. So
No. Is there any conditions where you suspect along with floaters, redness or pain or discharge?
If there is any uveitis.
Yes. Yes. So whatever negative questions you asked, you must be keeping something in your mind and then asking the questions, right? So you should have that answer ready.
Okay.
Yeah, to rule out any uveitic entity if you are thinking floaters like that. Similarly, why you are asking about water, no evidence of watering, photophobia, and headache.
Any history of any raised intraocular pressure.
Okay.
Then glare, colored halos, and we get for corneal edema.
Okay.
And then this distorted vision, and we ask in case if there is any macular pathology.
Okay.
Anjita, keep your mic little closer.
Am I audible, ma'am?
Yeah, better.
Okay.
Continue. Continue.
Yes, ma'am.
What is the problem? Move your slides.
My connection is taking.
We can, yeah, go back.
Your slides are moving, but we can't hear you.
Am I audible, ma'am?
Yeah.
Yes.
So coming to the past history, there is she is a known case of hypertensive and dyslipidemia on treatment since last 10 years. There is history of bronchial asthma and she is on inhaler. There is no history of diabetes and coronary artery disease, no history of an renal disease or CVA. There is no history of any blood
What is
dysplasia.
CVA?
Ma'am,
What is CVA?
any history of any stroke, cerebrovascular accident.
Okay.
There is no history of any blood dysplasias. A personal history, there is nothing significant. There is no history of smoking, alcoholism, or other addictions.
So why did
And
you, do you think any relation between the sleep and your present case?
no, ma'am.
Okay, we'll discuss when
Okay.
you discuss about the case.
Okay. And there is no significant family history. Coming to her general physical examination, she was moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. Regular in rhythm, normal in volume and character, no vessel wall thickening. Her blood pressure was 140/92 millimeters of mercury in left upper arm sitting position. Her respiratory rate was 16 per minute.
Anjita,
Yeah.
Hello. Her systemic examination was within normal limit. Coming to proper ocular examination, she has normal head posture. There is no facial asymmetry, orthophoric, extraocular movements, directions, versions, and versions were full in all directions of face. And her visual acuity in right eye, her unaided vision was 6/9, improving to 6/6 with plus 1.75 diopter sphere, and her left eye vision was 6/6. Her near vision was N6 with at +3 in both eyes, and her intraocular pressure was normal in both eyes. And coming to ocular slit lamp examination, and slit lamp examination of right eye and left eye was unremarkable. There was no evidence of neovascularization. Pupil was round, regular, reactive. There was no RAPD, and lens showed cataractous changes in both eyes. And on gonioscopy, she
Did
had
you
open
mention
angles.
about no NVI? Did you mention?
Yes, madam.
Okay.
And on gonioscopy, she had open angles. There was no evidence of any NVA. And coming to the fundus examination, in right eye, a slit lamp 90D biomicroscopy, the media was slightly hazy due to the vitreous hemorrhage, and disc was normal in size, shape, and color with well-defined margins. Cup disc ratio was 0.6 with healthy neuroretinal rim. Vessels arise from the center of the disc, branching dichotomously with an AV ratio of 2:3 in all quadrants. except an inferior temporal quadrant, which shows sclerosed retinal vein with a narrow retinal artery. The details could not be made out due to vitreous hemorrhage. And you can see there are corkscrew vessels along the superior arcade connecting to the inferior arcade, suggestive of collaterals that was seen superior and nasal to the fovea. And macula appears normal and foveal reflex was dull. There is discrete yellowish deposits temporal to the fovea, suggestive of hard exudates. And there are few scattered superficial hemorrhages seen along the inferior arcade. Here, the slit lamp biomicroscopy findings was confirmed with indirect ophthalmoscopy, and the periphery appears normal. And this is the slit lamp image of the 90D biomicroscopy of left eye that showed clear media. This is normal in size, shape, and color with well-defined margins, with a couples ratio of 0.6 with healthy neuroretinal ring. And the vessels arise from the center of the disc, branching dichotomously with an AV ratio of 2:3. And the macula appears normal and the foveal reflex dull. There is a waxy yellowish deposit seen along the superior arcade with vessels passing, this suggestive of drusen. Here, the slit lamp biomicroscopy findings was confirmed with indirect ophthalmoscopy, and the periphery appears normal. And summing up the case once more, this is a 67-year-old female, known case of hypertension, dyslipidemia, and asthma for 10 years on treatment. Complaint of sudden onset, gradually progressive, painless defective vision, and floaters in right eye for 2 weeks. And on examination, her visual acuity in right eye was 6/6 parts, and in left eye was 6/6. Her anterior segment examination shows cataract in both eyes. Fundus examination in right eye showed vitreous hemorrhage, inferior temporal sclerosed vein, and few scattered superficial hemorrhages seen along the inferior arcade. My provisional diagnosis in right eye was cataract, then vitreous hemorrhage due to neovascularization, probably an NVD or NVI, and there is an odd inferior temporal branch retinal vein occlusion and a grade 2 hypertensive retinopathy. And in left eye showed cataract.
Why you think it is old inferotemporal branch retinal vein occlusion?
Ma'am, there is an inferior temporal sclerosed vein and few hemorrhages along the inferior temporal arcade, ma'am.
So if it is acute, what you will see features?
In
How you
acute BR,
differentiate acute BRVO from the old?
ma'am, in acute BRVO, there will be
What type of hemorrhages you will see? When you say grade
no,
grade 2 what type of hemorrhages you will see in acute BRVO?
ma'am, in acute BRVO, am I audible, ma'am?
Yeah.
Ma'am, in acute BRVO, you get more of flame-shaped hemorrhages along the affected quadrant, ma'am.
And what else in terms of arteriovenous changes?
There will be dilated and tortuous veins,
Mm-hmm.
and you can sometimes get like macular edema along with the hemorrhages.
So you can find either segment distribution of either fresh flame-shaped hemorrhages, and you can even have sometimes dot and blot hemorrhages also. So depending on the level of ischemia. Whereas in bold, as you said, you have found a sclerosed vessel. So what do you mean by grade 2 hypertensive retinopathy? What is grade 1? Hypertensive retinopathy, what classification will be? Yeah.
Grade 1 is like we can see arterial narrowing in grade 1. In grade 2, there will be obvious arterial narrowing with focal irregularities can be seen in grade 2. And in grade 2, and along with retinal hemorrhages, exudates, and cotton wool spots can be seen in grade 3. And in grade 4, we can see papilledema.
So which we also call, there's another term, no? When you have papilledema along, we won't really say only papilledema, but along with whatever the hemorrhages, when you have disc edema, hemorrhages in both the eyes, what you will call that condition? Grade 4.
Like hypertensive optic neuropathy.
Hypertensive optic neuropathy is different.
Associated with a high BP.
Yeah. So is it a dangerous condition which requires some hospital administration and then management? Grade 4, when you see?
Yes, ma'am.
So
Yes,
it's
ma'am.
called malignant hypertension, right?
Malignant neuropathy.
Yeah. So why you think I asked about sleep history when you are presenting a case of BRVO? Is there any...
Means nocturnal hypotension.
So sometimes patients with sleep, if they snore, what condition they can get? Have an idea?
Obstructive sleep apnea.
Yeah, very good. So obstructive sleep apnea has been known to be, see, these are sometimes the risk factors, right? This patient has a very clear-cut risk factor of hypertension and then dyslipidemia. So not all patients may come up with those risk factors. So sometimes the patient could be obese and then he must be getting venous occlusion and repeated attacks of venous occlusion and edema. And you might have to ask when you say, when you have sleep appetite normal is not just for DNB format. There was a reason why we were asking all the systems. So sleep, sometimes we should always ask not just sleep, but also any snoring history and any apnea you should rule out, because you can have sleep apnea, obstructive sleep apnea can be associated with venous occlusions. Do you have any idea? Any other conditions in eye it can be associated?
Glaucoma.
Yes, very good. So anything optic nerve head circulation or basically cerebral circulation, whatever obstruction and all, you can expect normal tension glaucomas and even with the BRVOs. Good.
Anjita,
Yes, ma'am.
just hold on. So, Madam asked about what are the features of acute or a recent onset branch retinal vein occlusion. So, what are the features in this fundus which showed that it is not a acute onset? What are the clinical features that you saw in this fundus picture which showed that it is not a, it's an old venous occlusion?
Okay, ma'am. Here you can see an inferotemporal sclerosed vein along with some scattered hemorrhages.
Hemorrhages, you can get it even in acute also.
Some dot cloud hemorrhages. Then here you can see there are collaterals developed.
Where are the
developing from
collaterals? Where are the collaterals there?
I think the fundus picture is not there. You can just zoom if you can.
So what does, as Divya asked, what does collateral signify? What are collaterals?
Here,
Okay, no problem.
and,
What are collaterals?
here you can see
Yeah, I can see now. What are collaterals?
they means they are they originate from the capillary beds joining an obstructed to non-obstructed adjacent vessels. Like they will bypass any obstruction in any vessel.
No, where does collateral appears? What are they? What do you mean by collateral? Why collaterals occur?
Means to bypass an obstruction to drain means due to a long-standing ischemia.
No, why does collateral form and how they form?
Due to long-standing ischemia, due to release of waste.
No, where they occur? There's some junction, no?
So between what?
At the junction of the perfused and
They form like a bridge between what? We are telling almost the answer, me and Divya together.
Between
Between?
Yeah, between connecting what?
they're connecting between superior and inferior arcades. Means
No,
in
it's not the
upstream,
question of superior and inferior arcade. Collaterals
between
will form at the area of your venous occlusion. No, there is an
yes, ma'am.
ischemia. You said to bypass that occlusion, you said collaterals will form. So bypass that ischemia. So which junction they form and what is the differential for collaterals?
Neovascularization.
So if you understand collaterals, then you can tell about new vascularization.
Um,
So how do you differentiate it from new vessels?
we can differentiate it from new vessels on FFV.
Hmm?
Means neovascularization shows leakage.
No. Don't go to FFA. We're still in color fundus only.
Okay.
Clinical examination.
Mm.
When we see on clinical examination, how you will differentiate collateral from new vessels. And especially in
New,
this case, where you said that there is hemorrhage, right?
yes, ma'am.
So you want to rule out new vessels, correct?
Yes, ma'am.
So how do you differentiate collateral from new vessels? What are new vessels?
Ma'am, neovascularization, they can arise. They are formed at the junction of the perfused and non-perfused retina,
Mm-hmm.
and due to increased VEGF, means long-standing ischemia, that they leak.
So why new vessels appear?
Due to
Pathologically.
increased action of VEGF, ma'am.
Mm-hmm.
Long-standing ischemia causes releases VEGF.
Okay. So how you will, I will say that you are telling collaterals, but I will say they are new vessels. How you will say no, it is only collaterals, it is not new vessels. So what are the clinical features which will tell you, okay, this is probably what I am dealing is a collateral or what I am dealing is a new vessel. Is it important?
Yes, ma'am.
Whether to know it is a collateral new vessels? Will your treatment or management, will it change if you are suspecting new vessels? Or if you are
Yes,
thinking it is collateral, will it change? So what will be your treatment? If it is just, for example, this patient doesn't come with any complaint and she has only the sclerosed vessels and has collaterals. What will be your treatment? No, this patient now came with hemorrhage and you are telling collaterals are there. But if you are suspecting some new vessels, what will be your treatment?
ma'am. If it was
Management.
just okay, if it was just collaterals, ma'am, then we will just follow up the patient. But
Why you want to follow? Why, if it is only collaterals, why you want to follow? Why can't you treat? There is a collaterals in front of collaterals. What will be there? Is the retina will be perfused or non-perfused?
perfused, ma'am.
Perfused. So is there will be an area of non-perfusion when there are collateral form?
No, ma'am.
Hmm?
Retina is perfused.
At the area of occlusion, do you think there will be a perfused area or non-perfused area?
Ma'am, at the area of occlusion, means the collaterals will drain the long.
So why you don't want to treat collaterals?
Ma'am, collaterals are actually protecting.
Actually, I'm having little difficulty in hearing.
Anshita, you keep your mic little closer, or maybe we can ask other PGs also who are there online.
Yeah, so many are there.
Shine, are you there?
Yes.
Yes, madam.
Yeah. So clinically, how can you differentiate between collateral and neovascularization? That is ma'am's question.
Mm,
Yes.
Retinal collaterals originate from the pre-existing retinal capillary bed. It connects the obstructed and non-obstructed areas. So,
Okay, we'll come to one more easy question. So if there are collaterals, where all can form collaterals? Can you tell me any structures over which collaterals can form? One is at, we said that at the junction of perfused and non-perfused area. But anywhere else,
Oh.
and any structure you will find sometimes collaterals?
over the disc.
Yeah. So if there is an optic disc collateral is there, right? And for
Yes, ma'am.
example, there is a optic disc new vessels are there. How you will differentiate optic disc collateral versus new vessels? Because this is very important. This is a very favorite DNB question. If I am examiner, I'll ask only this question. So if there are collaterals on the disc, what is the difference between optic disc collaterals and optic disc new vessels? So what is the collateral vessel caliber will be compared to new vessel caliber?
Larger than the collaterals will be larger than the neovascular.
Okay, that is one difference. Then new vessels will be like a filiform, like your hair-like structure. It can be an abnormal structure, correct?
Yes,
And then what about collaterals? How do they optic disc collaterals? Will they be on the optic disc? Or what is that? They will be crossing over the optic disc or how it will be?
the pre-existing veins will be connected. Uh, uh,
They'll be. What about optic disc new vessels? Did you see any time optic disc new vessels, new vascularization of disc, NVD?
yes, ma'am.
So how does it look?
Irregular, fine.
Regular,
Irregular, fine.
mesh-like structure. Will it be limited to disc substance or it will cross the disc substance?
It will cross the disc.
So we are preparing answer together. Yes. So it will cross the disc substance. What about collaterals? Will they cross the disc substance or they'll be within the disc substance?
Within the disc, along the vessels, pre-existing vessels.
So the collaterals are like a compensatory mechanism. So they are like arteriovenous junction. They'll appear between the disc, perfused and non-perfused retina. So they'll be a little larger caliber than your new vessels. Whereas new vessels are like it's your breakdown of which barrier, how many blood retinal barriers are there?
Two, madam.
Two. So
Two.
what do you think new vessels are due to what? Which blood retinal barrier break? Inner blood retinal barrier is present between
the retinal capillary.
endothelium, right?
Endothelium.
Endothelial cells. So there will be pericytes. When they're all lost, when there is inner blood retinal barrier breakdown, you have vessel wall weakenings and all those things. And of course, diabetic retinopathy signs can appear, but also your VEGF. And then you can have all these ischemia, which increases, and then you can have this new vessels formation. Yeah. So new vessels will be always, could be, they can be little elevated substance. They may not be within the retinal substance, and then you can have a signs of hemorrhage. Divya, over to you for questions.
Yeah. So the new, as Madam told, neovascularization of the disc, the filiform vessel will cross the disc margin. Collaterals will be confined within the disc margin. Okay. So what are the signs? So which tells that this is an old vein occlusion. So once again.
This is an inferior temporal and sclerosed vein. Then collaterals.
Yeah. And you don't see much of hemorrhages there.
Not much of hemorrhages.
No intraretinal hemorrhages, no retinal hemorrhages.
So it is
right?
with
No, ma'am.
Okay.
So, any color coding for sclerosed vessel? Distinction mark.
Ma'am?
When you want to draw this picture, right? So you will not have color fundus Claris photograph,
Okay.
right?
Okay, madam. For
So how?
sclerosed vein, we use black, ma'am.
Yeah, black with
Um,
you can have crosses on that,
okay.
on the
Okay.
vessel. Yeah.
Okay, ma'am.
Okay,
Okay.
good. So where are non-fibrillary hemorrhages? Sorry, I told answer. Okay. So where? What is the difference between dot hemorrhage and blot hemorrhage?
Ma'am, dot hemorrhages are seen in a deep retinal layer, like in outer plexiform layer, and flame-shaped hemorrhages are seen in superficial layers, like in ganglion cell layer.
Huh? Ganglion cell layer. I
Flame-shaped
thought I
hemorrhages are
already told the answer.
ma'am in superficial nerve fiber layer. Sorry, ma'am. Nerve
Yeah.
fiber layer.
Why it is called flame-shaped hemorrhage? It's actually why it is flame-shaped,
Means the
because it
nerve fiber.
follows the nerve fiber layer distribution, right?
Yes, ma'am. Yes, ma'am.
What about blot hemorrhage? Is the
Dot
blot
hemorrhage.
hemorrhage is superficial or dot hemorrhage is superficial?
Dot, they are deep in deeper layers, ma'am.
Who are deep? Who is deep? Dot or blot?
Um,
In the answer, whatever I'm telling, in that only answer is there.
dot hemorrhage is more deep.
Hmm?
Dot hemorrhage is more deep.
Yeah, D for D. Dot hemorrhages are deeper, whereas blot hemorrhages. And so all these are all in inner nuclear layer is what retinal inner nuclear layer is where all these capillaries will end. Right? Inner nuclear and outer nuclear. So the more deeper the hemorrhage, like in outer nuclear, you can have a dot hemorrhage. Blot hemorrhage will have fuzzy borders. Okay.
Okay.
Okay. Next.
So a patient was systematically evaluated and she was advised to undergo FFA to look for any neovascularization, and OCT was advised to look for the foveal status
Why we did FFA?
to look for neovascularization, ma'am.
So is there any other investigation you can do?
Ma'am,
Without injecting?
oh,
So we have even,
OCT, ma'am,
yeah, OCT.
OCT was done to look for the foveal status, no?
So there is another investigation called OCT angiography. Now,
Angiography.
we don't require any dye injection. So
Okay.
without dye injection only, whatever you are getting in information in FFA, you can get, except that
Okay.
the leakage will not be seen. Okay, it's a dye-less visualization of retinal circulation. Suddenly in DNB, you might get a short notes if a retina person prepares questions. No, OCT angiography has a short notes. Recent advances, they'll ask, no, recent diagnostics. So in that, it could be there. Okay, go ahead.
So this is an FFA of right eye. Okay, this is the arterial phase, and this is the early venous phase. Here you can see the laminar flow has already set in, and here you can see block fluorescence, and this is block fluorescence. Here you can see hyperfluorescent areas suggestive of capillary non-perfusion along the inferior and temporal arcades. Then this is the late venous phase. Here you can see focal arterial narrowing is noted along the inferior arcade that suggestive of hypertensive retinopathy changes. And this is the recirculation phase. And here, this is the late phase.
So why are not you telling about collaterals? That is an important
And
finding, no? And again,
I
to
will
complete
describe
our
in
discussion
next
on
slide, ma'am.
Anjita, to complete
Yes,
our
ma'am.
discussion on collateral versus new vessels, FFA findings also you can add in that point. So if it is collateral,
Okay,
how it it will be. If it is a new vessel, how it will be on F.
Okay, ma'am. Here you can see collaterals connecting the superior to inferior arcuate and also along the fovea, nasally to the fovea. So you can see on subsequent frames there is no leakage. That is so it is not neovascularization.
Yeah, if it is new vessels, it would have like profuse, right?
Yes, ma'am. So here you can see a block fluorescence due to vitreous hemorrhage, and there is extensive capillary non-perfusion areas, and
Yeah.
there are Cox
So
fluorescence.
here there are two types of. You said here you are seeing block fluorescence due to vitreous hemorrhage. You said, right?
Yes,
And
yes, madam.
so what is the area that is next to the capillary? Sorry, next to the collaterals. That area.
Capillary non-perfusion areas.
Yeah. So it is a hypofluorescent area, right?
Hypofluorescent area.
Yeah. So hyperfluorescence can be due to here. What is the reason for hyperfluorescence? Here also you are seeing. So the block fluorescence, whenever you have like this vitreous hemorrhage, right? So you can actually, you should compare with your color fundus photo. You will know that, okay, there is a vitreous hemorrhage which is blocking. That's why there is a blocked hyperfluorescence. Whereas you have a capillary non-perfusion area, which is again hyperfluorescent and which is due to actually ischemia. So one is blocked.
Yes, ma'am.
Blocked fluorescence can always know by comparing with the color fundus picture.
Okay, ma'am.
So whenever, to add to that, whenever examiner asks you to describe a fundus fluorescent angiogram, always when you interpret, ask for a color fundus picture also. So I would like to see the color fundus picture. Okay.
So no
Okay, ma'am.
investigation should be interpreted in solo, clinical examination, then your color fundus photograph, whatever, and then slit lamp biomicroscopy, so then color fundus, and then FFA, OCT. Then only you will be able to make a correct, complete diagnosis.
Okay, ma'am.
And
So
here
you can
is
see.
actually, you can see the area of block of the vein. Are you putting that picture?
Yes, madam. Like so, here you can see this is
Your arrow is bigger than the block.
the areas showing block
Okay.
occlusion, ma'am. So this is the collaterals draining to this thing.
Okay.
So you can see the area of block there. And the collateral which is connecting inferior to that. You can show that collateral, the arrow
Collateral
connecting that to the vein.
In color fundus picture, can you show me which are veins and which are arteries?
Yes, ma'am.
Oh, you're enlarging, huh? No, I wanted to show in the same picture actually, which one you showed in the lab. Yeah. Okay, yeah.
Ma'am, the larger one is the vein.
Okay.
And this is the artery.
So when you say arteriovenous changes, right? What will be the normal arteriovenous ratio and then what will happen in hypertension? What is happening here?
Normal AV
What is
ratio
normal arteriovenous ratio?
2:3, ma'am.
So what can happen in hypertensive retinopathy as progresses? What are the
Artery
types
gets
of arterioles what are the types of arteriolar changes that are reported?
like AV
All ornaments. Huh?
focal narrowing.
Copper?
Anjita, say properly. Your mic is, keep your mic close. You're not
Yeah,
audible.
next time we can arrange in person. I will come to Kerala. Copperware, silverware, right? So what will become the arteriovenous ratio is, you said 2:3, right? Normal. So what it
Yes,
will
ma'am.
become? It can become even 1:4. Sometimes the veins can be dilated and tortuous, and then arteries can become so narrowed. Yeah,
Okay.
because you can see so that arterial narrowing so significant in this. So what are the types of hypertensive retinopathy classifications that you know? What is the famous one and what is the latest one? Okay.
I think maybe others can also answer. Atulya?
We can give homework also. They can
Yes,
write.
ma'am. Keith Wagner classification.
Yes. And anything else, which can, by seeing these arteriovenous changes and the hypertensive retinopathy changes, there is a correlation with stroke and death also. So what is that classification? Like, for example, stage 1, stage 2, stage 3, stage 4. So it has been correlated with the stroke and hypertension also. So there is a classification called Wong's classification.
Okay,
That is
ma'am.
actually by seeing the changes in the retina, we can predict their risk for cerebrovascular accidents and also mortality. So that is why it's very important. Hypertensive retinopathy one should comment upon because it indicates the systemic circulation changes.
Okay.
And another favorite things that you should also remember is the vascular changes. Like, for example, when there is a block, tapering on either side, like the Duke Elder book, gun sign, bonnet sign, distal
Salvage.
end. So those are all also very important things one should keep in mind.
Okay.
Yeah, next. Anjita is it? Yeah.
Out of the FF of the left side, but that seems normal. This is an OCT of right side. Here you can see there is a hyperreflectivity and
Anjita, you are not audible. Keep your mic closer.
Yes, ma'am. Am I audible now?
Yeah.
Yes.
So this is an OCT of right eye showing an hyperreflectivity anterior to the vitreoretinal interface suggestive of a vitreous opacities and with some back shadowing on the retinal layers. And retinal interface seems normal here. The foveal contour is maintained. And here you can see some dysregulation of the inner retinal layers. The layers which cannot be clearly outlined here. And the RP and Brooks complex seems to be normal. And here there is some hyperreflectivity suggestive of some intraretinal hemorrhage here. And there was no evidence of macular edema.
Just go back to the OCT, Anjita. So what are those hyperreflective dots in the first OCT? Yeah.
Some hard exudates was present adjacent to macula. No? The
Yeah.
hard exudates.
Opposed to hard exudates. Okay. Always, even when you interpret OCT, also always compare with what session in the fundus that OCT scan has gone through. So never interpret an OCT just by seeing the OCT B scan alone. but always compare it with the fundus area where it has been taken. Then only you should interpret.
Okay.
So what does that, you told there is a disruption of the retinal layers. What does that signify? What do you call that actually? What is the short form of that?
Drill.
Huh?
Disregulation of inner retinal layers. It is called drill.
Drill. Okay. So what does it signify?
Means a chronic inflammatory process. You get disruption of the inner retinal layers.
Chronic inflammatory.
Means
Shine.
Chronic ischemia.
Ischemia. So that
Ischemia.
signifies ischemia.
So you
chronic.
see, it's very simple to see that, the one side you are having all the layers, you can say that. Also another term called parallelism, like, retinal layers, all 10 layers, you can see like a rows, both hyperreflective, all those bands and everything. Whereas you are not able to see those structures. And BRVO, characteristically, by just seeing OCT, you can know whether it is a BRVO or is it something related to more diffuse process, because you can see whatever the disruption is occurring only on the temporal process in that segment. So like segmentally, you're seeing the changes because that particular tributary, vascular supply has been obstructed. So by seeing OCT, you will be able to also know what kind of disease process you are actually looking at. And there is so much thinning, right? And these are all biomarkers, right? So you might right from ganglion cell layer to inner layers, outer layers, you should see what are all the changes which are suggestive of, again, it also will show some of the signs will also indicate that it is a old branch retinal vein occlusion.
Yeah, so as Madam mentioned, you can see that there is slight thinning of the inner retinal layers temporally. Yeah, when you take OCT of this case, when it was in an acute phase, you might see there might be an increase in thickness with an increased hyperreflectivity of the inner retinal layers. So as it becomes an old one, it becomes disrupted and you cannot make out the layers and becomes thinner. So that is how you differentiate between an acute and a old venous occlusion. Okay. I think continue.
So like there is no clear-cut evidence of any neovascularization. So the VH might have probably caused by a PVD. So this patient was managed conservatively, and on subsequent visit, like since there was an extensive CNP areas, and since the patient was a non-compliant, so we do infect a PRP here, which was advised to follow up at 3-monthly interval.
So if it is a PVD-induced hemorrhage, what are the things that you will look into? Most important.
If it was a PVD, along with VH, then we have to look for any peripheral, any retinal tear.
What type of tear? What type of tears are associated with the posterior vitreous detachment? Because if you know the type of tear only, you will be able to look for it, right?
Oh, yes, sir.
Huh? What? A round atrophic hole, will it cause a PVD-induced vitreous hemorrhage?
No,
Lattice with hole, will it cause?
no, madam.
But where it can cause? What type of tear?
Like in the periphery.
Periphery only? What type of tear? If the tear is there, you can know that there is a
Hole.
PVD. Here only you are assuming that it could be a PVD induced. It may not be.
Okay.
Because whatever the investigation that is possible, you did FFA. And because there is no bright fluorescent leakage from the collaterals, we are assuming that there are no new vessels.
Okay.
Right?
Yes.
No, not okay, ma'am. What could be the type of tear that you should see to say that it
Ma'am,
could be PVD?
a horseshoe tear.
Horseshoe tear, yes. And for example, how many times you can find in a PVD induced vitreous hemorrhage horseshoe tear? But there could be sometimes PVD induced hemorrhage can occur. Can it occur without any tears? Is it
Ma'am,
possible? PVD induced hemorrhage can occur without any retinal tears? Why occurs PVD when it is induced? Why hemorrhage occurs? What are the vitreous strong attachments? Why it should occur only peripheral tear? All homework should be submitted to Divya.
I think Atulya can answer that question.
Ma'am, the attachments are the strongest one is over the vitreous base,
Yes.
then around the vessels, then around the optic nerve. So since there is traction over around the vessels, it can pull the vessels and across the vessels and across the blade.
So some 60% of the time, PVD induced vitreous hemorrhage can cause HSTs normally. So that's why it's very important to look again and again whether we have missed any horseshoe tears. And sometimes when the blood settles down, every week one should examine. So how do you follow up? You said follow up at 3 months. And if you think that it is a PVD induced vitreous hemorrhage, do you want to call at 3 months or you want to call a little earlier? If want to call earlier, why?
There may be chances of tear developing later due to the traction, which
So it can be
restriction.
an evolving PVD,
Okay.
So there are times probably the maximum that I treated was 16 horseshoe tears in one patient. So they can be very holy people. So one need to be carefully observe each quadrant and you can find HSTs and it can be a tessellated background. So these are not tears which can be, which are not easy to detect or do laser completely. So Divya used to be my favorite person. So to write that, okay, these are the HSTs, please do laser. And we mark and, we know that, and we should also look again 360 degrees carefully in the laser room. So that used to be the standard instruction because you can find more horseshoe tears can happen. So these patients require a closer follow-up if we are thinking in terms of PVD-induced vitreous hemorrhage.
Anjita? Any more slides? Okay. So can you get vitreous hemorrhage in an acute case of venous occlusion?
And if yes, why? Without neovascularization.
Patient comes with a history of 2 days. No past history of any decrease in vision or anything. You see there is a CRV or sometimes VRVO and you are seeing a vitreous hemorrhage. Can you get it like that?
So any other history you will ask in this patient? Because we asked so many negative things. But I think one point was missed in your history because if you are suspecting a hemorrhage occurred and you have a old venous occlusion and you are not really seeing any new vessels, any other particular positive history you will ask the patient, which can also probably result in exercise, result in bleeding.
Answer was there in the question only.
Yeah, I'm actually telling all answers actually. It has been long time asking questions.
So what are the causes of vitreous hemorrhage?
Yeah.
Anjita?
If would you ask this patient to do yoga and deep breathing exercises?
Valsalva maneuver can
Yeah.
cause, ma'am.
Anything which can cause rise in pressure above neck, so it can cause. So that instruction holds good for all these hemorrhages, wherever you suspect new vessels, because new vessels lack endothelial junctions. They are very friable. They're compared to your regular vessel caliber, they can just bleed. You might be seeing and you might have advised laser, and then after laser, they may break through. It's just because of any exertion, any sudden bending. All those things also can have anything which can cause increased venous pressure above the neck can result in vitreous hemorrhage. So it's important to ask any heavy exertion happened, any sudden, any vomiting episode or any exertional activity above neck also should be asked. And that can be one finding which should be there in your history. You can mention negative finding if it is not there. And then anything in systemic investigations, anything else, very favorite correlation of any systemic parameter associated with venous occlusion, along with, you said dyslipidemia, you said hypertension, but would you like to rule out anything else?
One more usually investigation.
Very common done investigation.
Blood investigation. Anju?
Homocysteine.
Yes, very good. So serum homocysteine levels will do. So venous occlusions, whenever, depending on the age, you do these investigations. Same picture can be there in a young patient. Then your entire battery of investigations could be different. Then you will also rule out inflammation, cells and any inflammatory BRVO. So any vascular occlusion, depending on the age group, you will tailor your investigations. Of course, in 67-year-old, the hypertension, those things will be the most common, but one should keep in mind, depending on the age, you will do the investigations. A58.
Yeah. Okay. So I think from this presentation, at least you should be able to make out how can you differentiate between an old and an acute branch retinal vein occlusion, and what are the causes of vitreous hemorrhage. And when you have a vitreous hemorrhage in a patient with the venous occlusion, the investigation like angiogram is to be done to rule out if there is any underlying neovascularization, and also to see the extent of capillary non-perfusion area. Because that extent of capillary non-perfusion, as per the criteria, if it is more than 5 Dis diameter, then there is a high risk of developing neovascularization. So these are, and all the clinical points, fundus pictures, which gives a clue that it is an old venous occlusion. That is a hard exudates, collaterals, and if there is any NBD or NBE, all these gives you a clue that it is an old venous occlusion. So all these few important points you should remember. And then again from the OCT, how to differentiate between an acute and an old venous occlusion. Again, we have discussed that point. So I think.
And hypertensive retinopathy classifications.
Yeah. Anything else to add, ma'am?
Yeah, perfect. Perfect summary. And yeah, tailor-made investigations as per the age group. Yeah.
And that question we asked, actually, patient can present with the vitreous hemorrhage even in acute venous occlusion. So don't always think that vitreous hemorrhage, so it is because of a neovascularization. That is because of the sudden occlusion, and there is a venous congestion which causes bleed. So it's not always because of the NVE or NVD, and don't jump for a PRP or anything. And laser should be done only once the hemorrhage, retinal hemorrhage is resolved. And you should be knowing about the parameters of laser also. Okay, so then I think thank you so much, ma'am, for sparing your precious time with us and to teach our PGs.
Thank you. Thank you very much.
Thank you, Anchita, for presenting.
Yeah.
Okay.
Bye.
I think we shall
Yeah.
meet up. I think Marian has left.
Yeah. Thank you, Marian. Thank you, Divya. Thank you, everyone.
Ma'am.